Welcome everyone to today's webinar, Innovative Ways to Improve Operating Margins for the Nation's Essential Hospitals. On behalf of Becker's Healthcare, thank you for joining us. Before we begin, I'm going to walk through a few quick housekeeping instructions. We'll start today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session will be recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you don't see your slides moving or you have trouble with the audio, please try refreshing your browser. You can also submit any technical questions into the Q&A box. We're here to help. With that, I'm pleased to introduce Allison Aranth, Senior Vice President of Client Development and Marketing at Clearway Health. Thanks for being here today, Allison. I'll now turn the floor over to you.
Randy, thank you, and good morning. And to everyone, thank you for joining today's webinar. On behalf of Clearway Health, we're grateful to Becker's for having us, and I'm extremely thankful to America's Essential Hospitals, who are wonderful partners and advocates for the essential hospitals and health systems across the U.S. Today, we're excited to talk about ways to improve operating margins for each of the organizations that are represented here. America's Essential Hospitals is a leading association for hospitals who are dedicated to providing equitable and high quality care for all. The work that they do is tremendous, and we'll hear a bit about Bruce Siegel, who leads this work for this organization here in just a couple of minutes. Clearway Health is a company that was born out of a health system, Boston Medical Center Health System, who was one of the founding members of America's Essential Hospitals. And Clearway Health focuses on building specialty pharmacy programs to support hospitals, health systems, and community health centers across the U.S., remove barriers to access to care for patients, and to support clinicians as they move through specialty pharmacy journeys. And from America's Essential Hospitals, I am thrilled to introduce Dr. Bruce Siegel. Bruce has been a part of this organization for many years, and before that is no stranger to healthcare, has served in many different capacities at two different health systems, both New York City Health and Hospitals, as well as Tampa General Healthcare, both of which are members of America's Essential Hospitals today. Nicole Fauché joins us as the president of Clearway Health. Nicole joined Clearway Health about a year and a half ago and has led the development of this program as it has grown out of the services that were created to support and serve the community of patients that Boston Medical Center Health System serves, and now serves hospitals, health systems, and community health centers across the U.S. And so with that, I'm excited to lead a discussion with both Bruce and Nicole today to really talk about innovative ways that each of their organizations are supporting hospitals and health systems and the work that's happening in all of their communities. And so Bruce, I'd like to start with you and really talk about the challenges that your partner hospitals are facing as they're looking to remove these barriers and deliver equitable care for all people in their community. So I'll turn it over to you.
Well, thank you, Allison, and thank you, Nicole, for having me here today and for our partnership. And more important, I want to thank all the folks who are with us today, joining us on this, I think, an important event, and hopefully one that'll open some of our eyes to some of the opportunities as well as the challenges out there. You know, thinking about your question, you know, there's a few things that I'd want to point to as sort of the big challenges, and some of them are kind of new, and some of them I think are no surprise to many of the folks who are joining us today. You know, we are seeing certainly in the, I guess, the wake or the tail of the pandemic, huge challenges for health systems, especially our essential hospitals, around issues of labor costs. You know, we've seen the Great Resignation, we've seen the incredible necessary use we had of temporary staff. But, you know, to this day, many health systems I talk to are seeing just huge budgetary pressures, you know, tens of millions of dollars per year in extra unbudgeted expenses to cover added labor costs, still to bring on temporary staff, to meet the market for all their staff, not just nursing, across allied health professions and really across everything. And that is really leading to some pretty severe financial headwinds for a lot of health systems, including, I'm sure, many who are joining us here as well. I don't know if that's going to go away tomorrow. I think in some ways this is a realignment and a restructuring that's going to be here for a while. And refilling this pipeline of healthcare workers and rethinking how we deliver care is going to take a bit. The other couple of things I'd point to real quickly, one which is also relatively new, at least the last few years we're seeing, is the rise of new competitors who want to go after a piece of your business, usually on the outpatient side, usually with a higher margin. That could be folks even like Amazon today or Optum, also private equity. And I think the concern there is, pressure on your margin, but also sort of a disintegration of care as different pieces of it are taken over by different new actors in this space. And the last one I just mentioned, known to everybody here. If you're in the 340B program, and I suspect just what everybody here today is, you by definition are treating lots of folks on Medicare or Medicaid, especially Medicaid, with low incomes. And that means you're getting paid less to provide health care. We know from data from the Kaiser Family Foundation, for instance, that if, on the inpatient side, commercial insurance often pays twice as much as Medicare and even more so than Medicaid, outpatient side 4 times. So if you're in the 340B business, if you're in the central hospital business, you are facing a huge challenge. You just simply get paid less for providing the same care. And that's a long-standing challenge.
Bruce, thanks for that. You talked about these different forces that are impacting healthcare and the services and the work that's happening. Nicole, I'll turn to you to talk a bit about the response to delivering high quality care in the face of these forces and what Clearway Health is seeing in that space.
Yeah, I certainly want to echo the thanks for everybody for joining, and certainly want to build upon what Bruce was already describing. I think part of what we see from our seat at Clearway Health is that, a lot of the challenges that organizations are facing is a bit of where do I spend my time, where do I spend our dollars, and how do I sift through the noise around those things that can really be accretive or incremental to the services we provide in a way that best service 3 stakeholders, right? Patients, providers, and the system. And that can be very, very challenging. I think that healthcare for, well over a decade at this point is constantly looking at how can technology solve this problem? How does that investment work? And even, the last few months, very heavy discussion around AI and technology. And does this have empathy that matches or exceeds providers, which is somewhat comical in the scheme of things. But I think the challenge that, if you really sift through all of this, it's that while on any given day, we don't feel that healthcare has changed a lot, the reality is that it has, whether it was, sort of inspired by the pandemic. And from our standpoint, what we really want to look at is really providing, and through the conversation today, is that there are ways to solve the challenges around workforce, challenges. There's ways to look at reduced margins that Bruce mentioned through the different payer mix that you may have, through some more novel approaches to leveraging services that might exist in the system today, but in new spaces. And so we're really looking forward to talking through that. And I think the most important part of it is there's how do we do this more with less, essentially ideas that we're always working through. But I don't mean do more with less people. I kind of would like to turn it like, how do we do more with less burden? And I think that's kind of a key point I'd like to really talk through throughout our conversation today. And I think this is where elements like 340B, specialty pharmacy can really alleviate some of those challenges.
Yeah, I'd like to add a little bit to what Nicole said there. When I started out in this world, probably too long ago, the opportunities were generally seen as, how do I move more volume through certain service lines. So, classically it was orthopedics or cardiology or cardiac, surgery. And that was a sustainable model, perhaps, back then. And in some places it may still be today. But I think what we're seeing now in the movement towards value and the movement towards really looking at things like population health and now total cost of care, I think it poses a question of how do we effectively manage the patients we have today? How do we make sure that we're not spending more resources than we should on their care by keeping them as healthy as possible? And that also takes work out of the system and maybe a less need for more staff and more spending. And more importantly, how do we sort of achieve the best outcomes, outcomes possible for our patients? And I think things like what we're talking about today, specialty pharmacy, are part of that. Not only do you begin to better manage patients and do it outside the hospital, you also meet them where they are. You empower pharmacists to be on the front lines and be those frontline providers. And you also develop relationships with these patients, very patient-centered relationships that really build affinity, which is good for their care, which begins to truly deliver on the promise of population health. So I think we've moved. Payment models have changed. They're going to continue to change, and patients expect a lot more. And I think this is one big opportunity to do that and do it in a way that is forward-thinking.
Yeah, absolutely. That's great. And I think that forward-thinking approach really starts to tee up some of the opportunities and things. Bruce, you talked about service lines that have historically been strongholds for health systems and how an opportunity now is thinking about that differently. Nicole, I want to go back to you to really talk about some of these opportunities to either build or strengthen service lines that already exist. You talked about novel approaches and solutions. Tell us a little bit about what some of those might be.
Absolutely. And Bruce, I appreciate sort of a bit of a tee up for this one, because I think what you ended with is kind of where I'm starting. Just want to paint a bit of a picture for a moment. When a patient is at a provider practice, let's say a specialty provider, and recently received a new diagnosis, recently is now receiving a new medication or treatment plan, one of which might be scary, very complex. Where do they go from there? They might get a little bit of in-clinic sort of patient education, but then they go to the pharmacy, right? And they have their prescription filled, hopefully. We know that about 50% of the time they actually don't fill it. So hopefully they go and continue their care with their pharmacist. From that point in time, a lot of data has shown that a patient in any given year will see their pharmacist at least 10 times more often or interact with them 10 times more often than their provider or their provider practice. That's pretty staggering. And so if you're a health system and you have, let's say, an outpatient pharmacy that may or may not be, focusing on specialty medications at this point in time, immediately when a patient is diagnosed, they're actually maybe going to, let's say, a national chain, another local pharmacy, and immediately another relationship is sort of intersecting that care, right? And that is both important related to the patient relationship, to the provider, to the health system, to their outcomes. And so one of the things that we are really passionate about is closing that loop. When you talk about the intimacy of a pharmacy relationship and embedded in a clinic, and you can sort of triangulate all those relationships, what it is the patient commitment to their care, right? Their compliance to their care is incredibly higher. And that high compliance results in better clinical outcomes, which certainly helps total cost of care and the health of the community. It drives potential revenue or absolute revenue for the system that is incremental and new at a much higher operating margin than a typical service might be, including those that are usually high margins. And on top of that, a patient loyalty that is really important. So when we work with our customers, and this is across facilities that are everything from pediatric hospitals, FQHCs, academic medical centers, and safety net hospitals, when you have a patient attrition rate that is less than 2%, meaning that the patient is not choosing to unenroll in a program or continue their compliance with their treatment plan, it changes the entire dynamic. And the things that are in play to help drive this sort of revenue producing opportunity that also supports patient care requires an embedded specialty pharmacy program. And what's really unique about that is it moves the pharmacy, which long historically would be a cost center, or at best, let's say, single digit margin opportunity for a hospital, into something much, much bigger. And this is something that there is inherent skills. They might need some surrounding support because of the complexities related to new and specialty medications. But what it does is it strengthens some of the relationships that already exist and already, exemplifies that without creating something that's more abstract and saying, hey, I haven't seen a demonstration of where this will drive exactly what we're describing here. So this idea of, patient engagement, provider engagement, and tying tightly back to the patient care plan, I think is the biggest driver around why specialty pharmacy has the ability to be so important to a health system, financially, operationally, and clinically across the board.
Yeah, Nicole, I didn't know some of those statistics, and that was amazing to hear. And I have to say, from a DC perspective, one of the benefits of this is that it's overall, it's going to save the healthcare system money. These are often conditions that are very expensive, especially if they're not cared for properly or compliance isn't there and adherence. This is really a win-win. They may be high-cost therapies often, but if you look at the actual total cost that you're going to incur, especially for the system writ large, it's going to be big. So impressive.
Absolutely.
Bruce, one of the things you talk about often, as I hear you talk about the work that America's Essential Hospitals is doing, is really getting a grasp and managing the business that a hospital or health system has to help improve margin for existing business, while in parallel looking to growth. But having that strong foundational business with high incremental margin is something that I hear you talk about. Talk about opportunities, challenges, maybe as it ties to some of those margin opportunities for current patient populations that are being served.
Well, I think if you look at the patient populations that our hospitals serve, they are people who are vulnerable. They are people for whom, frankly, given the inequities we have in our payment system and how our hospitals get paid, for which there really isn't adequate reimbursement. I know, for instance, when we look at our membership, our hospitals are providing about 8 times the uncompensated care of average U.S. hospitals overall. So we begin really with a huge disadvantage in terms of just keeping the doors open, and which is something, frankly, the 340B program was created to do when Congress created it back over 30 years ago. So to the degree that our hospitals also care for much sicker and more complex patients than the average hospital. I can show that to you in our case mix index. I can show that to you in a lot of different statistics. And if we can better manage these patients, provide superior outcomes as a result of that, specialty pharmacy, appropriately, garner the savings from from specialty pharmacy and 340B appropriately as good stewards of the program, that helps our hospitals to meet their mission in their communities. And there's no reason why we should be apologetic about that, and we should, pursue that opportunity and seek it. Certainly, we want to grow. Not against growth, but we also have to deal with realities, especially in highly competitive situations, where you, as an essential hospital, may be competing with other organizations who, have much different payer mix and different, ability to invest in capital. This tends to even the playing field, specialty pharmacy, as do other things. And so I think it's absolutely critical for hospitals to take a close look at it, because you're helping your institution. More importantly, you're helping the people who depend upon you.
Yeah. You I think you nailed it. And when you talk about ways that the leaders on this call can take these concepts back into their organizations, I think it's also important to talk about the support and the infrastructure that's there with the purpose of supporting these essential hospitals. And you've talked about 340B, it's already been mentioned a handful of times. There is funding that is available, governmental and otherwise, but especially in the face of recent 340B conversations. And Bruce, you just talked about the importance of that program to support the care for these hospitals that are providing more than 8 times the amount of uncompensated care than other hospitals in the country. Talk about ways, Bruce, we'll start with you, that we have to maintain focus to protect and defend these funding sources for these hospitals.
Yeah, so as you know, it's a big question, Allison, and I'll try to, and I could talk about this for 5 webinars, not just one, so I'll try to keep it short. You know, 340B is very much in the crosshairs, and I probably spend more time in my job now dealing with the incoming on the 340B program than any other issue that we have in front of us as an association. You know, our association was actually instrumental to creating the program back in 1992. And the hospital that was really of record then was Parkland, which was used as the case study to help establish the program over 30 years ago. I think today we are facing huge problems. We are facing a very well-funded, coordinated campaign coming from the pharmaceutical industry manufacturers to curtail, cut back, however you want to put it, undermine the 340B program. And I think we, our hospital leaders, you on the line, need to be utterly unapologetic about this program and why it's here and what you do with it. This program was created to stretch the scarce resources of safety net hospitals. That's what's in the congressional record. It does that today. And it allows hospitals, nonprofits and publics, you know, so charitable organizations, to do things they couldn't otherwise do. And we can, you know, we'll talk more about that later, about what that looks like. But when we defend the program, we need to realize that if we don't defend the program, what we'll see is really resources that can now be invested in our community through the things that all of you do here. Resources that can pay for charity care, resources that can pay for that food pharmacy to deal with, you know, food insecurity in your community. And I know many of you face that. Those resources will be taken away from our essential hospitals and our essential communities and go into shareholder returns for drug companies. It is literally that simple. And to put a finer edge on it, at a point today where we probably are seeing most American hospitals losing money because of the labor costs I mentioned earlier, the pharmaceutical industry routinely generates over 20% operating margins. I mean, there's no equivalence here to what's happening. And we need to defend the program aggressively and assertively. And all of you on this call today are probably the best spokespeople to do that. You know, for us, that defense means defending it, you know, in the regulatory arena. You know, we've been fighting over the issue of contract pharmacy. I won't go into that much detail. You all are familiar with that. And then, you know, getting HHS or trying to get HHS to enforce the rules. And it's tied up in litigation, obviously. We have fought it in the legislative arena. And I think mostly successfully, but it's still been a challenge. Lots of activity today on the Hill about trying, you know, looking at the 340B program, which we're frankly trying to inform and curtail. And then we fight it in the courts. You know, we were very happy to be a key part of the litigation that led to the cuts to under Medicare to 340B hospitals in the outpatient arena being deemed unlawful by Supreme Court last summer. And in the last, you know, couple of weeks, HHS has announced plans to pay back about $9 billion to 340B hospitals with some caveats for this. So a lot going on. We need to fight it on every front. And I think most importantly, we need to fight it on the front of the narrative. This program, the critical program, which actually costs the federal government nothing and actually may save it money in various programs, allows us to do things in our communities that couldn't be done otherwise. And if we didn't have 340B doing this, we'd have to find some other way to pay for it, and that would fall upon our taxpayers. So, full-throated defense, we got to keep going. We cannot let up.
Bold statements, Bruce, and appreciate the comments. Nicole, you talk similarly about the sensationalism of 340B and these other funding sources. Any thoughts that you would add to Bruce's here on this topic?
I mean, I think the few things I'd want to add is that I think the sensationalism, for those that may not be as intricately involved in all of the items that Bruce was talking about, when you see the things in the news, I think it sometimes implies a level of risk related to the program or people participating. And I think it's important that people recognize that that is not really the case, that there are elements that are being called out in a way that if it's making you pause, then they're going to think that they've been successful in the scenario of what it's been creating. And that really is not the case. Instead, our role as relates to protect and defend it is to ensure that we're supporting organizations like Bruce's and many others. But on top of that, ensuring that when we're working with organizations, that we're working through and navigating as best as we can the various sort of headwinds or random things that are coming across these days, whether it's things that are happening in the news, manufacturer actions, PBM actions, et cetera, because the reality is, as Bruce said, we came from, Boston Medical Center health system, firsthand have seen that the role that 340B plays in serving a community that otherwise nobody is paying attention to in the extent that this can is immeasurable. Like their dollars aren't available otherwise. And, whether we're going to talk, I'm sure we're going to talk today around, how do we see this program supporting these communities? But the reality is the money does have to be available. And this program doesn't cost taxpayers. It's funded in a way that's very different. And I think that for our space, what we want to make sure we do is that we're educating people, that they understand how to participate in the program if they're, an eligible entity, and then that we do so in a way that best suits their organization and in compliance with what's expected. And I think my biggest hope is that people aren't deterred from the program because of things that they might hear that makes it seem as if there's challenges ahead.
Yeah, I'd like to just sort of underline what Nicole just said, because I do hear that sometimes, sort of perception of risk and the like. 340B program is not going away. That I want to be clear about. I mean, there's going to be, these conversations on the edges, maybe more than the edges sometimes, but the program's not going away. If only for the reason that the last place Congress likes to be is between hospitals and the drug industry. That's not a good place for them to be. And I don't see anything, happening that dramatic. It's going to be here for a long time to come, and people should use it to improve the health of their communities.
Great, thank you, Nicole. Thank you, agreed. We've talked a lot about the challenges, we've talked about opportunities, we've talked about ways that there is infrastructure to help to support this continued work. And so the shift now is to think about, when we talk about specialty pharmacy specifically as an opportunity for essential hospitals to improve operating margins, if we align it to themes and strategies that are critically important to every single organization here, we talk in terms of population health and patient consumerism. Nicole, I want to start with you. When you talk about ways that patients are seeing a pharmacist 10 times more often than their care provider, and you talk about a less than 2% attrition from patients who are enrolled in being served by a specialty pharmacy program, what are some of the ways that this program does have impact in these communities on population and public health, as well as patient consumerism?
So, I think at times when we start thinking about I started one of the last questions talking about the fact that 50% of medications that are prescribed aren't filled. And that number actually gets further worse if you start thinking about refills and how long people stay compliant with their care, right? If you were to just, by and large, think about compliance to a treatment plan in and of itself should result in better healthcare outcomes and better health management, then the simple idea of if you have a complex care program or complex medical care program and a medication therapy management program that's a part of your value-based care program, and you're targeting it in that way, knowing that pharmacy is one of the largest expenses that could exist as it relates to your cost of care, and you start looking at strategically focusing on those patient populations, then just by virtue of math, you've got the right sort of combination of focus points to have a shared risk or risk-based model, right? Now, in the event that you are in this type of arrangement or considering it, and you don't have a specialty pharmacy model that supports it in a way where you are actively involved with the patient, not just from a patient navigation standpoint, but complex care management, chronic disease management. If you read any of the ongoing information around the American Hospital Association or others, where they start looking at, the prevalence of this more complex chronic diseases is not stagnant. It's not going down. If you start thinking about comorbidities, diabetes, hypertension, and ongoing, and you look at the incidence of cancer diagnosis over the next 5, 10, 15 years, it's sort of staggering, right? We have to put our hands around how do we manage these patients well. On top of that, the FDA is approving more specialty medications compared to other approvals that are happening or other ages where the ability to manage these medications, educate on them, and dispense them through your pharmacy is another key element related to the population health. Again, if you think about sending people out into the community to fill in the care gaps or medication prescriptions that are occurring within your system, you're starting to lose a little bit of control around that. So, when you think about that, that's really a key area. From again, going back a little bit with our history with Boston Medical Center Health System, by and large, one of the very most wonderful things they have there is the control of or management of about 400,000 lives under their care around a mass health ACO, which is somewhat of a unique arrangement compared to many other states. And in that arrangement, what's happened over time is the lives under management has continued to grow because the ability to manage the costs in order to manage the outcomes and the quality of the care that's provided continues to be proven time and time again. One of the key areas, if you were to talk through the team that manages that whole group through BMC, is that it really is an anchor to specialty pharmacy and pharmacy services as a whole, right? Again, going back to how often are we engaging, how do we drive it? The last piece that I'll say to that is, patient consumerism is just really interesting. If you were to ask 10 people, how do you describe it? They would give you 10 answers. And how do you address it in your org? They would give you 10 different ways they address it. I think that's a little bit, currently being reviewed quite often. But the idea behind it is, are you looking at the patients and serving them in a way that they have these choices, right? That they want to be more of a consumer of the services than you happen to be, that they have choice in the matter, right? And so working through that and serving it in a way that is very patient-centered, maybe technology-enabled, but certainly more ubiquitous to what's actually happening for the patient, then I think you can tie in this concept of population health, patient consumerism, into a revenue-producing service line altogether.
Yeah, I would just add a couple of things to that. We live mostly today still in a fee-for-service healthcare system. And, many times I've seen leaders be hesitant to walk down the population health pathway because they might see disincentives in it, frankly. If they're still in a fee-for-service world, they might see it as a revenue dropper or a margin dropper than an increaser. I think one of the positives about specialty pharmacy is that it aligns those incentives, regardless of what sort of environment you're in. It's basically saying, you can do population health, you can reduce the amount of care our patients require, the cost of it, improve their outcomes, and frankly be rewarded in some way for that, and see a positive contribution margin rather than a negative. That's hard to prove in a lot of population health work today. As of today, it may change in the future. Specialty pharmacy actually accelerates that and aligns with incentives in ways you don't usually see.
Thank you both for that. There's, I see some questions coming in, one of them specifically about some clinical programs as it ties into population health and consumerism. I know questions are at the end. I'm gonna layer this one in now though. Nicole, for you, there are clinical programs and you talk about them often for specific cohorts of patient populations. One of those that I hear you talk often about is hepatitis C. There are others. Are there ways that these type of clinical programs that are driven by a specialty pharmacy backbone are creating positive population health impact?
Yeah, thank you. Sorry, I had a little feedback from it. That is a really great question. So from a clinical standpoint, the disease states that we tend to look at really sometimes vary by state or population that we're in. And I think that's really important, right? You really have to understand and have the data at your fingertips to really look at that. But by and large, if we were to talk some of the large ones that we spend a lot of time on, it would be around hepatitis C programs. That's one that really services two key areas. One, not only does it help relate to the total cost of care, our team did an evaluation in one of the areas, one of the states that we do a lot of work in, and found through looking at such that, the incidence of hepatitis C undetected was second highest in the nation, and the impact to their community was quite high. And so in partnership with their clinical team, we leveraged a playbook that we have around, the approach, everything from how it's screened through the EHR, through what it means really to embeddedness within the clinical practice, the treatment, the medication, et cetera, and really outlined, hey, the cost within your community, if these go undetected until a point in time where they're considering, let's say, cancer diagnosis, liver transplants, et cetera, the burden is really quite high. This is a place where, one, through the 340B program, you can offer this sort of hepatitis C screening, provide this population overview and community benefit. And so that's really one area. We look a lot around chronic disease management, diabetes, which is probably a pretty obvious one, but around appropriate management of their hemoglobin A1Cs, and really looking at how is it being managed and monitored, providing clinical pharmacy some opportunity to provide feedback through their lens to the clinical providers, and really look at improving some of that management through different medications that are out there. By and large, if you think about it, if something seems to be working well for a patient, it's really unlikely that you would transition that medication to something newer that might be available. And so this is a way to kind of look at that. One of the things that I'll add on top of that, we spend a lot of time related to, HIV, infectious disease programs. We look at rolling out programs related to interstitial lung disease, and et cetera. So it really kind of depends on the program at large. But one of the things I will add to this that I think is not what you're asking, but really critical, is we start looking at, through some of our client sites, how often in a patient management is a provider taking into consideration a clinical ambulatory pharmacist feedback related to the medication use. And what we found in some cases is sometimes as high as 75% of the time, there's an opportunity for a better management from the medication side in cooperation with the provider and the pharmacist. And about 75% of the time, that's accepted through the provider. So it's a great partnership with the provider that feeds into a lot of that population health management. So, I mean, we could go through a lot of different areas, but I would say that it really depends on the population we're working with in the community.
Sure. Thanks for talking about that specifically. I think your thoughts on those clinically specific programs, and then Bruce, the thoughts that you shared on ways that specialty pharmacy help us to align with this fee-for-service type of structure, tease up this next topic for conversation. The reality is, as we talk about reinvestment of dollars that this type of program can create through improved operating margin, there is very much a phased approach. Maybe on day one, and this is true for many of the health systems that we partner with, there is a need to keep doors open and to meet payroll. And as you build this program to help improve the financial standing of an organization, there's incredible opportunity to do some of the things, Bruce, that you talked about, like the food pharmacies and the continued improved access within the community. So Bruce, I'll start with you to talk a bit about some of the reinvestment opportunities that this type of program creates.
So, it opens up a world of opportunities, and I can, mention just a few real examples out there that we know of. So certainly, I mentioned just the much higher levels of uncompensated care our hospitals provide, and keeping the doors open to do that is even by itself a wonderful thing to see happen. But then we see many of our hospitals, once they have these programs in place and can realize the savings, go beyond that. So, for instance, we have seen some of our hospitals invest in managing opioid use disorder across their community in outpatient setting, using these savings to reinvest there. We have seen, at least I know one major center, actually be able to open a level 1 trauma center in a very needy community. And this is, talking mostly about, penetrating trauma. So usually, so it's not, in any way profitable. And do that because the program gave them the flexibility and the financial space, actually, to be able to do that. And this was something that was, not present before for miles around. I've seen some of our essential hospitals build primary care medical homes using the benefits of specialty pharmacy and the 340B program. We've seen folks establish clinical pharmacy programs and really put pharmacists, position them as frontline primary care providers, which I think is a great thing and really helps to improve access. I mentioned food pantries before. There's been, investments across a range of social risk factors, including, housing and educational opportunities. These are all things that health systems are doing. They're doing it today, and they're able to do it often in large part because of appropriate use of the 340B program to stretch those scarce resources as the program intended. One other thing I'll mention, this is maybe more a political thing, than a clinical thing. When people critique the program or critique hospitals being in it, one thing I like to point out to them is our hospitals have an obligation called EMTALA, Emergency Medical and Treatment and Active Labor Act, about 40 years, which says that all those hospitals on the line today have to see every patient in their emergency department and at least stabilize them if they require that. That's an obligation no other part of the health system has, and that's just one of the reasons why we need something like the 340B program and specialty pharmacy.
Thank you for sharing that, and I think everybody on the line can align and attest to that. You talked about a lot of these opportunities for reinvestment, and throughout the conversation today, there's been clinical components, operational, financial pieces that are wildly important to the ways that these programs create improved operating margins. There are a handful of questions, and before we get into those, I'd like to open the floor for each of you just to share any advice if people are leaving this conversation at whatever stage they may be in considering ways that they're looking to improve operating margins and thinking that specialty pharmacy could be an opportunity for them. What advice would you offer them? And Bruce, we'll start with you here.
Well, I would spend a lot of time looking at this and trying to figure out how I can make it work for me. I travel pretty much every week. I'm at, usually more than one, institution, either virtually or in person, usually at least one in person. And this is something that is moving through our segment of the industry. I most times when I sit with a CEO, she'll tell me, we're looking at specialty pharmacy. oh, actually, we are doing it, and it's been a boon to our patients and for our organization. So this is something that is happening. And I think for those who are not there, I think it's something you absolutely need to take a look at. I haven't run across anybody who said, I'm sorry I did it. That's for sure. It's been literally 100% positive. And I've seen that happen. I've seen this again and again and again. And I would point to it as being one of the largest trends in our membership over the last 3 or 4 years that I can tell just from one-on-one conversations. I would say an advantage, which you've talked about, Allison, that Clearway brings is that you're actually rooted in a real health system that has been at this for years, that actually owns a large health plan, so it's used to accountability, including for low-income Medicaid patients across an entire state. So I think there are multiple folks in this space, obviously, that's all good. You're actually tied to people who actually deliver care and are, part of them, literally. And I think that brings something to the table that, we often don't see. But definitely, people should be looking at this and probably doing it.
Bruce, thank you. Nicole?
I have thought about this question so many times, and as throughout the course of this conversation, like, where would I really land? And I would say there's a few things that I'd like to sort of demystify or demyth a little bit. I think that the idea, Bruce already said this, around something's going to happen to the 340B program. I would say, 100% agree that the 340B program is not absolutely going anywhere. So do not be skeptical as to what's happening. But I would say seek some partnership and advice, because I think that it does become more complex. I think the idea that that outpatient specialty pharmacy programs are reserved for large institutions or those that have a certain type of patient population is a myth that needs to be debunked. I think that if you are an organization, you should heavily consider an outpatient pharmacy and a specialty pharmacy program and not be reliant on a contract pharmacy situation. While they are important partnerships, I think some of the navigating of what's occurring currently related to manufacturer restrictions and contract pharmacy activities really creates an opportunity to reevaluate what the specialty pharmacy strategy is at an organization. And it's one that, it's not a wait and see. We're up to 24 manufacturers that have, or probably more since we've been on this phone call for all I know, 24. And, we really have to look at how do we strategize to do that. And pharmacy really does have, especially pharmacy has to be a center of that. It is an opportunity to really grow the system. The last thing I would like to say is that the idea of this, though, is that this is not just a pharmacy function, right? It's not, let's talk to the pharmacy team. They are a critical part of the program. Absolutely no doubt about it. But I think talking to the providers, embedding in the clinics, working with the different leadership, working with, your employee health plans. I mean, there's just an opportunity so large in this space that when you start talking about what opportunity does specialty pharmacy have in your organization, it's even bigger than just pharmacy conversation itself. And so I would just sort of enhance that audience, and you start talking about this this opportunity within your health system. And like I said, look with a partner, because I think it's really important to have some outside eyes helping provide some insight around what's really occurring and how do you navigate the changes that are inevitable over time.
Thank you. Thank you both. There are many questions that have come in, and we'll work through a couple. If you have others, please add them into the chat, and we'll be sure to address them either here or as a follow-up. Let's start with one, Nicole, that comes out of one of the myths that you just debunked. And this question came early in the presentation and the discussion today, which is, if you look at all of the compelling reasons for specialty pharmacy and 340B, why wouldn't every hospital or health system develop this program? So will you dive a little bit deeper into what some of those myths might be and reasons why these organizations should not consider a specialty pharmacy program?
So I'm going to take that question in a couple of parts, because I think it's more than one thing. I think that entities that find themselves eligible for the 340B program, by and large, are participating. I think the bigger question is, do they understand the full opportunity ahead of them? Do they fully understand their community? And do they understand that even a small community hospital might have upwards of $60, $80 million annually of opportunity. And are they satisfied with where they are today? And I think if they fully understand what's possible, they might change the strategy. So I think most systems that have 340B eligibility are participating. The second part to it, I think, is should they have their own pharmacy? And I think it's a rare instance where I think you would not want to have that. And it depends a lot on some information for each entity involved. But I think as the environment has continually evolved and changed, it's changed the dynamic of relying on contract pharmacy and moving to an ownership model. And today, I think about 40% of hospitals and health systems own a pharmacy. So a good bit do, but by and large, many do not. And so I think that's where I would go is how do you really understand the full opportunity ahead of you? And are you prepared and able to really capture that? Because it's an annual opportunity, right? You cannot go back. You have to really start building for the future.
Sure. A piece that has come through in kind of a couple questions that ties into this, Nicole, is this concept of understanding exactly what that opportunity looks like. So for those organizations who have a program or have started doing some of that work on their own, any advice for how to really understand the maximum potential for what specialty pharmacy could provide to their organization?
The specialty, when you look at the specialty pharmacy program, it's an understanding of, one, the patient population, your specialty mix, right? The size of the organization, the types of medications that are being prescribed, understanding the prescribing habits and behaviors of the providers, where they're being filled, how they're being filled, who in the organization is responsible for ensuring that there's an opportunity for that to actually be filled and paid for. I mean, but you take all those things in together, because again, a prescription that's ordered is not necessarily a prescription filled. So you want to understand what is prescribed, and you want to understand what is filled. And so in tying those things together, all this information is available within your EHR and or pharmacy system. Certainly happy to help in that calculate and work with you to understand what that looks like. But it's all available at your fingertips. It's just understanding how to put it all together.
Good. Thank you. Bruce, the next question, I'd like to start with you. The question that came in from the group today is related to the population health conversation, and specifically, how do you balance population health programs and the growing strain on access to care?
That's a great question, and I think, you know, many of our health systems really want to do the population health work. They want to really get to those social risk factors and social determinants of health, but they're having a hard time keeping the doors open. And you know, they at budget time are thinking to themselves, well, these are great programs we have that take us outside our four walls, but we can't afford to keep these access points open across our community, our clinics, or we can't be engaged in this service line. So I think there's a strong, I wouldn't say conflict, but there's a desire to do more outside the four walls, which is being challenged by, I got to meet payroll, and I got to at least make sure I keep a minimum number of access points open. And I will say that we have seen hospitals closing access points in our membership because they need to meet payroll, because they just can't afford to do it anymore. And that's a painful decision. I think, well, I can tell you, I know that specialty pharmacy actually changes that equation, because first of all, it may free up resources through savings in the program to allow you to maintain the access points, and maybe also continue to make those investments in the community. So that's one thing. But the other thing is that the program, specialty pharmacy in and of itself, is a population health program. So Nicole mentioned hepatitis C earlier. If you're in the rural Southwest of the United States, hepatitis C is I don't know if I'd call it epidemic, but it is rampant. It is so prevalent, and the outcomes are terrible if it's not treated. The therapies are miracles compared to what we had years ago. And a program that can help make sure people who might be at risk are identified, are appropriately cared for, are plugged into a system of care which improves their health and also generates, positive margin for the institution so it can do these things. I don't know why you wouldn't do that. And I'm not sure that requires an academic medical center. I mean, if you're a community hospital in the rural Southwest, you are facing this every day. This is part of your reality. And this can help you begin to change that picture, both, for the people you serve as well as your hospital.
Can I add something to that, Allison? I think there's an element to that that's really, really important. By and large, in agreement with everything Bruce just mentioned. I think there's an element here, though, where we don't want to forget about the very critical role of a clinical pharmacist as an extension of a provider practice. So if you think about how, people working at the top of their license or the type of patients they can see, if you think about the patients that are visiting and going to a practice or using that time, what we have seen is that using a clinical pharmacist as an extension of that practice, taking patient visits for medical therapy management or MTM type services as an adjunct to access has been a huge contributor to improving that access point. And often done as a non-billable sort of event. It's just a view. And then what we're doing at that point in time is freeing up other clinical time for other patients, making it easy. These can be sort of phone or telehealth type visits or otherwise organized, but creating this care team that sort of is an adjunct to the typical delivery within the clinic has been a huge opportunity for improving access. And in fact, there's been many discussions with some of our clients that we work with around how do we even help some of our community hospitals around us who maybe aren't embarking in such a way where we can look at extending or helping fill these gaps. Because again, any patient who's sent to, let's say, a specialist but can't get in for 6 months in and of itself starts creating access gaps almost right away. And that at that point, we're not even really talking about some of the more difficult, even primary care access from time to time. But so I just think, look, again, creatively, how can pharmacy and clinical pharmacists be a part of that care team has been a complete differentiator related to improving access within a system.
Good. Thank you both. We are nearing the end of our time. I would share a couple closing thoughts, and Randy will pass it back to you in a moment. But Bruce would just say thank you to you and to America's Essential Hospitals for the diligent and incredible work that you do every single day. We're grateful for your partnership. Nicole, you started talking at the beginning of the hour about this concept of how do we do more with less burden. And I think this entire conversation has highlighted the undeniable challenges, but the undeniable opportunity that health systems have. And so the work that is happening in these essential communities every single day is astounding. And so we are grateful for those that have joined the call today and who have joined the conversation here as both two partner organizations, America's Essential Hospitals and Clearway Health, to be a resource to all of you. So thank you for your time. We are grateful for it. And Randy, with that, I will pass it back to you.
Thank you so much. As mentioned, that's all the time we have for today. I want to thank Allison, Nicole, and Bruce for an excellent presentation and Clearway Health for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. Thank you for joining us and have a wonderful day.